Welcome to the Integrative Medicine Podcast. I'm Dr. Jordan Robertson. In this podcast, the best of both worlds of medicine come together, informing you of your healthcare options. This podcast is for the ultra-discerning, highly critical, and results-oriented health consumer, filtering out the good, the bad, and the real ugly when it comes to health information. As your host, my mission is to help you navigate the world of evidence-based integrative care and confidently make choices to help you live your best life. Enjoy! Welcome to another edition of the Integrative Medicine Podcast. I am your host, Dr. Jordan Robertson, naturopathic doctor. Today, we are going to be focusing on miscarriage and miscarriage assessment in our 6th episode of the podcast. And today's episode is important to me for many reasons. I have discussed publicly that I have a personal history with recurrent pregnancy loss, having miscarried 3 pregnancies in a row during my final year of naturopathic medical school. And I also have recently published a practical guide for the public, a book titled Carrying to Term, which is currently available on Amazon in either hard copy or in an electronic version, which was written for sort of very determined women who are interested in understanding their health as it pertains to fertility and who want to have an active, autonomous role in their fertility journey, who are looking to better understand the risk factors for miscarriage and who are looking for the additional supports they can do from a diet and lifestyle perspective to help improve their odds of either conceiving and carrying to term naturally or improving the odds of any fertility intervention that they're pursuing. I'll discuss the book a little bit more at the end of the show. So today I want to focus on miscarriage assessment specifically. And you know from listening to previous episodes how important this concept of assessment is to me. And when I get interested in a topic, I do a couple of things as far as trying to understand what my role in healthcare would be with these particular patients. And I also like to look from sort of a public health / global perspective, what our understanding of this disease is, whether or not we vary as far as how we support a condition or disease based on where patients live and the kind of medical care that they have access to. And miscarriage is really no different. I've found that globally we treat women's health issues very differently, with Canada being one of the only countries where family physicians are the entry point for most gynecological or obstetric concerns. Canada is the only country where PMS, where pregnancy, where miscarriage, that the family doctor may be that first point of contact for these women, whereas in, sort of our top 4 or 5 other highly medically developed countries, patients have the ability to access obstetricians and gynecologists as a direct entry point to their support with women's health. And so this may actually change the kind of support that we offer Canadian women. I know I have listeners beyond Canada, but it's interesting to me, and these concepts are interesting to me. And it comes up again when we start to look at miscarriage, because North America may be the only sort of developed medical nation where we are not routinely screening for things like thyroid disorders or antibodies against thyroid that may actually be putting women at risk for pregnancy loss, whereas in some European countries, we're actually screening women before attempting to get pregnant, recognizing sort of the importance of early screening and intervention in preventing events such as miscarriage. So we have some challenges with assessing miscarriage, partly because of the way that we've defined recurrent pregnancy loss. And so from a clinical perspective, most women don't actually, I'm going to use like quote unquote qualify for a more in-depth assessment as to the cause of their miscarriages until they have satisfied that diagnosis of recurrent pregnancy loss, which is 3 or more miscarriages. And so once women clinically have satisfied that, they start to qualify for additional diagnostic techniques to try and sort out why they are having these multiple miscarriages. But interestingly, when we start to look from an assessment perspective, there are multiple studies that suggest that the third miscarriage is happening for the same reason as the second miscarriage, which is perhaps also happening for the same reason as a woman's first miscarriage. And so, unlike other medical conditions where the frequency that things are happening may actually change the diagnosis. So I use this example in the book, and I talk about hives. So I'm going to use that example now because I think it kind of illustrates the point the best. So if patients have hives one time versus having hives every day for a year, 2 things happen. One, we care more, right? So having hives once, we may say, oh, look, there's hives. You must have come in contact with something that is you're allergic to, and it produced a hive or allergic reaction. So we don't care quite so much. When patients have hives every day for a year, we care more, right? We think, my goodness, there is an underlying issue that's happening here that we need to pay closer attention to just because of the frequency that it's happening. The sort of severity of what's going on, or our interest in what's going on goes up. But another thing happens is that the cause of your hives actually changes. So the reason you have hives once, maybe you're exposed to strawberries or a cat or something that you are, is environmental. So not only are we not super concerned about it, but the cause for it is maybe sort of inconsequential, or we're not particularly concerned about it. If you have hives every day for a year, the reason you're having hives changes. It might still be a cat, and maybe you live with a cat and you're having cat exposure all the time, but it also increases the potential that you're having an underlying systemic illness that is creating this susceptibility to having chronic daily hives. So 2 things happened there. The how much we cared about what's going on goes up, right? With the frequency, the more often it's happening, the more we care, or the more significant or severe it seems. But the reason also probably changed. The first exposure was because you had strawberries, but the multiple repeated chronic daily hives actually means that there is another different underlying condition going on. Now, with miscarriage, we actually find the opposite. So certainly from a woman's perspective, the concern and severity of a single miscarriage is just as significant as her second, third, or fourth miscarriage. But interestingly, what we're finding is that the reason that women have multiple miscarriages is probably the same reason that they had their first. And so we may actually have less challenges or less emotional trauma or less lost pregnancies if we started to assess or explore the reasons why women were having miscarriages a little earlier on in their diagnostic process. There's actually 2 reviews that looked specifically at this, where they found that in recurrent pregnancy loss, the diagnostic cause for the third miscarriage was the same as the diagnostic cause of the second miscarriage. And they both went on, so two authors. One was Ford, and the second one, the Ford article is published in 2009, and the second one is Jaslow, 2010. They both went on to suggest that earlier screening and diagnostic techniques should be introduced for women before they satisfy sort of that true diagnostic criteria of recurrent pregnancy loss. And I would say clinically, after working with this population of women for some time, we probably could prevent these episodes or the trauma of having to experience miscarriage by doing some earlier assessment when women have had 1 or 2 miscarriages versus waiting until they satisfy that diagnostic criteria. The complete other side of this story is that we can actually predict who is at risk for miscarriage before they have one. And so our greatest causes of miscarriage where we can have a significant impact, I would say certainly there are physical causes that increase risk of miscarriage. There are infectious causes. There are genetic causes. There are lifestyle causes, alcohol, caffeine, tobacco, illicit drug use. But when we look from like a medical perspective at the issues that we should be screening for, we're falling much more into the camp of looking at the endocrine causes or the autoimmune causes of recurrent pregnancy loss or miscarriage. And for these particular patients, we can actually predict their likelihood of miscarriage before they even attempt to get pregnant. And that's what I wanted to focus the discussion on today. So the couple of assessment techniques that I wanted to focus on today as far as predicting future miscarriage risk was looking at BMI and the role that obesity plays in spontaneous pregnancy loss or miscarriage. Also looking at insulin and testosterone, so extracting this from looking at women with PCOS specifically, partly because this is one of our most common endocrine disorders in women, which we think about 10%, perhaps more women of reproductive age are struggling with insulin insensitivity and PCOS. That certainly makes it one of our most common causes of endocrinology-related pregnancy loss. And I also want to look at low serum progesterone in the luteal phase. And this is actually relatively recent research that has come out since I published my book, specifically looking at the levels of progesterone that need to happen in the luteal phase in order for us to reduce our likelihood or risk of miscarriage. And this is likely pertaining to our women who have an actual luteal phase defect as the cause of their infertility, patients who have endometriosis or who have poor progesterone reception in their uterus, or women who generally have poorer ovulation rates or low progesterone in their luteal phase, such as women with maybe low body weight, excessive exercise, or premature ovarian failure. And lastly, I want to focus on the concept of using universal screening to assess women for hypothyroidism or subclinical hypothyroidism, as well as the presence of antibodies, as in the case of Hashimoto's thyroiditis, which is a very common cause of recurrent pregnancy loss. And the evidence is starting to suggest that women should be universally screened for antibodies before attempting getting pregnant, especially when we start to talk about secondary infertility, or for women who are experiencing miscarriage after an initial successful pregnancy. So before I talk about BMI, I'm going to skip over that and talk quickly about the impacts of insulin on miscarriage rates and the importance of testing fasting insulin and HOMA-IR as it pertains to women with PCOS, but also women who don't satisfy the full diagnostic criteria of PCOS, but who are struggling with insulin insensitivity, either are pre-diabetic, and as this pertains to obesity. So essentially for women with PCOS or polycystic ovarian syndrome, we know that this is a mostly insulin-driven scenario, meaning that women have higher than optimal levels of insulin release, that their tissues are less receptive to insulin, and this creates essentially a pre-cardiovascular disease scenario. These women also make excessive levels of homocysteine in their liver as a result of high levels of fasting insulin. And so they're basically what's happening in their vascular system is mimicking what we would maybe expect from a much older, much more overweight patient with established cardiovascular disease and diabetes. And so the reason this is important is because during implantation and while we're trying to establish healthy placental utero connection, so mom to embryo connection here, we actually are establishing new blood vessels. And so when we do this in the context of cardiovascular disease or sort of early cardiovascular disease is what we see in women with PCOS, we actually have a reduction in the percentage of the kinds of arteries in the placenta that are required for good, healthy placental development. So there was actually a study that was done looking specifically at placental health. Palomba 2012 is the article, looking specifically at the amount of arteries and the competency of the arteries in women who have PCOS in their placentas. And what they found was, in general, that these arteries had established cardiovascular disease, meaning that they were inflamed, they had high homocysteine, there was a reduced number, and the size of these arteries was also impaired in women who had PCOS versus women who did not have PCOS. And this was all correlated to their fasting insulin, to their HOMA-IR scores, which compares their fasting insulin and their fasting glucose. This was comparable to their testosterone levels, to their oral glucose tolerance test, as well as their weight. And so what we're finding is that when we're trying to reduce this risk of miscarriage, looking at insulin sensitivity, looking at weight management and BMI should become one of the predictors we can use to predict whether or not women are at an increased risk for miscarriage. Because as we're trying to develop a healthy placenta, these women are doing it in the context of inflammation and cardiovascular disease in newly formed blood vessels. And when this happens in the context of trying to produce a good ureteroplacental circulation, the placenta is not well established, and that does increase the risk of miscarriage. And so we can predict if these women are at risk simply by running a fasting insulin test and a fasting glucose test, and then using that in the equation to predict equate the HOMA-IR score. And so most of the studies are looking at HOMA-IR scores of over 2, 2.5. Some studies use 3.5 as a cutoff, although I would say that that's very insulin resistant by that point. But when patients have a HOMA-IR score of above 1.9 or 2, they are already showing signs of insulin resistance, and that's going to increase their likelihood of having miscarriage. Women with PCOS will also have other androgens or other lab work that is abnormal when tested, and testosterone levels above the reference range also predict a likelihood of miscarriage. And so that would be a reasonable test to look at, especially in our subset of patients who are experiencing PCOS or who are suffering with PCOS. So fasting insulin, fasting glucose, and testosterone are our greatest predictors of miscarriage risk in women with PCOS. Now, moving away from that, just specifically looking at BMI. And so certainly we can argue that maybe BMI doesn't tell the whole story of a particular patient's health and well-being. However, when we stratify patients by BMI, and so there is a author CUI, done in 2016, where they actually went back and looked at more than 2,000 charts of patients who are undergoing either IVF or ICSI procedures at multiple fertility clinics in the United States. And what they found was that, in general, the patients who were overweight miscarried a quarter of the time. And so these were established positive pregnancy tests. This is different than just a straight up failed cycle. So it doesn't mean that 75% of the women went on to achieve successful pregnancy. It's of the women who had a positive pregnancy test, which is a low number to begin with, that a quarter of those women then went on to miscarry. Whereas women who had a normal BMI or who were closer to their ideal body weight, they only miscarried 10% of the time or 11% of the time. And so irrespective of their diagnosis of PCOS, we found that weight was an independent predictor for miscarriage. And so the study even went on to compare women with PCOS and without PCOS, and they found it actually didn't matter, that they miscarried just as often based on weight alone, even if we didn't take sort of their underlying cause of miscarriage or infertility, which in this case for some women would have been PCOS. Even if we took that out of the equation, BMI became one of the strongest predictors of miscarriage risk. Next, I want to move into discussing thyroid health and looking at subclinical hypothyroidism and Hashimoto's as a cause of miscarriage. So I've got a bit of a logic problem here when it comes to how we make decisions around screening for low thyroid. And so let me just say a couple of points here, and I illustrate these points in my book as well. So interestingly, if we just screen women universally, meaning that we don't base it off symptoms, right? So traditional thyroid screening looks for women who have a positive family history, who report symptoms that are common in hypothyroidism, such as poor metabolism, poor body temperature regulation, fatigue, etc. So universal screening would mean that, independent of symptoms and independent of family history, we would just test all women. So if we universally screen women that are of fertile age, we detect low thyroid or find the presence of autoantibodies against the thyroid twice as often as if we based it on their symptoms alone. So universal screening will pick up Hashimoto's thyroiditis and hypothyroidism of other causes twice as often as just testing women who present with symptoms. Now, women who have subclinical hypothyroidism or true hypothyroidism, or who have antibodies against their thyroid, are at an increased risk of miscarriage. And depending on the status of their thyroid and their levels of antibodies, their increased risk is 2 to 10 times more than women with normal thyroid function, depending on which lab tests we're looking at. If we treat women who have low thyroid or who have antibodies against their thyroid, even if their thyroid appears normal, we reduce their risk of miscarriage. Most societies have published position papers against the use of universal screening for thyroid disorders in women who are attempting to get pregnant. So you can see why I have a little bit of a logic problem here. If we test, we find it more. If we treat it, we miscarry less. But we've published position papers saying we're not going to look. And so for women who have had recurrent miscarriage, I think testing antibodies is one of the first steps we should take, thyroid antibodies, especially when women have had what we call secondary infertility, meaning that they've successfully carried to term at least one other time and now is suffering with miscarriage. The likelihood of developing Hashimoto's increases in the postpartum period. And so in women who've had a previous successful pregnancy, that may have actually been the impetus for them to develop thyroid antibodies, which we only discover when they start to struggle with fertility in their second time around. So a full thyroid panel for these women looks like testing TSH, T3 and T4, sort of our more functional thyroid hormones, as well as antibodies against the thyroid, including thyroid peroxidase or TPO and antithyroglobulin. The interesting thing about the research is suggesting that even if the numbers are almost normal or fairly normal, but there is a presence of autoantibodies that we actually need to support women so that their thyroid is working better than average. Pregnancy is a transient stress on your thyroid. And if you have low thyroidal reserve going into your pregnancy, that transient stress may actually push women who sit in the bottom of the reference range or the close to hypothyroidism or that subclinical hypothyroidism. That transient stress on the thyroid from pregnancy may actually be enough to push them outside the range. And especially if you've had a previous miscarriage, we would want to support thyroid economy in a way that actually prevented that transient stress from actually inducing hypothyroidism. I will be discussing the treatment of subclinical hypothyroidism in prenatal care for the treatment of recurrent pregnancy loss or reducing the risk of miscarriage in another podcast episode, as it's a pretty significant topic. But from a screening perspective, and that's what I'd like to stick to with today, from a screening perspective, women who are attempting to conceive, who have a positive history of thyroid in their family, who have had a previous pregnancy and are now struggling with secondary infertility, or have had one or more miscarriages, really should be screened for that thyroid blood work that I mentioned previously, including thyroid antibodies. The last thing I want to focus on is the potential new use of testing serum progesterone levels in order to determine the likelihood of success of any given cycle. So interestingly, the utility of testing progesterone maybe up until recently, was pretty limited. We use serum progesterone levels to confirm ovulation in women when we test them in their luteal phase, trying to hit for about 7 days after their predicted ovulation, or approximately day 21 of their menstrual cycle. So having a progesterone level over 10 or over 12 is highly predictive that that woman has ovulated in that cycle. But we really had a hard time using that number to predict the success of that cycle. So if the woman's progesterone was 12, that was sort of no better or no worse than having a progesterone level of 30 or 50. But up until recently, we've started to realize that perhaps the level of progesterone in that luteal phase is predictive of the success of any given cycle. And we're seeing it most often right now with medicated or treated cycles, meaning that women are having sort of advanced reproductive technology or IVF used to help stimulate and induce a cycle, and that progesterone levels or the readings that we're seeing on blood work might actually be predictive of whether or not those women carry to term. So, like I said, this is a newer concept, but what we're seeing in these sort of there's about 4 studies currently that have been published in the last 6 months on this topic, is that progesterone levels in the bottom 10%, progesterone levels below 15, or with medicated cycles, progesterone levels below 35 when tested, seem to predict poorer outcomes or a greater likelihood of not only a failed cycle, but also a miscarriage. And so this might be actually the first time that we can use luteal phase progesterone to predict the likelihood of success of any given cycle. And hopefully this turns into a better understanding of how to apply progesterone as a treatment for women that aren't undergoing medicated cycles. Currently, about 75% of medicated, or I use the term medicated, but I mean cycles where they have assisted reproductive technology, 75% of those cycles are being medicated in North America now with progesterone, either after embryo transfer or after IUI. Women are being medicated often with a vaginal progesterone because we know that increases the likelihood of success of those given cycles. What I hope we learn over the next couple of years is whether or not using progesterone in women who have a reported low progesterone, say below 30, seems to be maybe an appropriate cutoff, whether or not using progesterone in those women who are attempting to conceive naturally actually decreases their risk of miscarriage. And that's something we'll have to watch for coming in the research. That's a missing link in the information that we have up until this point. So just to recap on a few things that were touched on in this particular episode, while focusing on assessment with miscarriage, it's interesting that what we're finding in the research is not currently trickling down to the way that we screen or manage women who are at risk of recurrent pregnancy loss or even a single pregnancy loss. For a screening test to be valid, from a public health perspective, it needs to be cheap, it needs to be reliable, and early screening and early intervention needs to dramatically change the outcome in order for us to sort of heavily invest in a screening process, which I think makes sense, right? We can't put thousands and thousands of people through a screening test that's going to catch 1 or 2 additional cases. But when we're talking about miscarriage risk, the things we're finding is that earlier screening would certainly benefit a subset of women who are going to be at risk for recurrent pregnancy loss. And although I only spent time on the endocrine causes of recurrent pregnancy loss in this podcast, I do cover a few of the other causes in my book, Carrying to Term. Because the other side of earlier screening or more universal screening for risk means that we need to have well-established treatment options for the things that we find. And so in women who test positive for fasting insulin that's elevated, who have a high BMI, or who test positive for Hashimoto's, or perhaps who have low progesterone in their luteal phase, each of these concerns actually has very accessible and very easy intervention in order to right the wrongs that are getting in the way from having a healthy pregnancy that's carried to term. I do go much further into the treatment options for all of these concerns in my book, as I mentioned, which is available on Amazon. It's called Carrying to Term. It's a practical guide for women who are looking to reduce their miscarriage risk and who are willing to learn about the potential lifestyle, diet, supplement, and medications that are available depending on their diagnosis to help them understand how to carry to term. It also gives patients the language that they need to have a good conversation with their primary practitioner, whether it be medical doctor or naturopathic doctor, to help them be well assessed in order to try and prevent recurrent pregnancy loss or potentially a first miscarriage. My goal with writing the book was to help women feel like they had more autonomy in their fertility care and to give them, like I said, that language to have a very positive and proactive conversation with their healthcare practitioner about being properly assessed for miscarriage risk. The link to purchase the book is available in the show notes, as is a free downloadable guide for all of the lab work that should be considered to help reduce your risk of recurrent pregnancy loss. This concludes our episode of the Integrative Medicine Podcast. As I strive to bring you the tools and advice you need to make well-educated healthcare choices, I hope you listen along. Questions about the podcast or topic requests can be forwarded to our email at imedresearchhub@gmail.com. Remember to subscribe to receive updates on the latest episodes through iTunes, Stitcher, or Google Play.